All right, you guys, we are going to go ahead and get started. Welcome back, everyone. Good to see everybody, or at least see your names. Thanks for those that put their faces. I enjoy that. What I want to start out with today is I want to go over just kind of review a couple things on the test and what's coming up, and then I've got one date change to make on you guys, and then we'll kind of get into it. But first, I just wanted to talk about the test. In looking over the scores and things, it looks like we did pretty good on this test. Um, you had as you'd expect, you had a bell curve going. We did have one person that got 100%, so our bell curve kind of on the high end, with not many being at 100%. We had that out there, and then on the low end, we were somewhere around 76% or so. Which technically still passes your boards, right? So. um, so pretty good bell curve. Most of the meat of the bell curve, or the biggest width of the bell curve, was somewhere in the 90s, in the 90 percentile. So that tells me you guys did pretty good with just a few outliers and things which we'd expect. So good job on that. I see a lot of you have turned in your test corrections. Remember to do those again. Like I've mentioned before, I don't make those required, but they are a very, very important part of the learning process for you to kind of go over what you missed and kind of re-solidify it in your head. And so thank you for those who've turned in those. I haven't graded those yet. I was kind of waiting to get past this lecture, and then I'll go back and kind of do everything and look at everything that you guys have done already. And so I'll look at those. Also, it looks like most of you, or at least a big chunk of you, have turned in your module for the first section. Awesome. Great job keeping up with the class. Those of you that haven't yet, please try to get that done so you can kind of move on to our section 2 here, and kind of keep up with the class. And if there's any of you that are struggling for whatever reason and not getting things done, let me know, and if there's anything I can do to help you, I'm more than happy to do that. And so I'll get all of that in the next few days, kind of graded out so you guys can look at it, and we'll go from there. The other thing I need to talk to you about is I need to make a date change, and I hate doing this to you guys because I know your schedules are probably more set than mine has to be right now with school and work and class and everything. But I had a family event come up that I can't get out of that I need to attend. So our next class is supposed to be April 9th. It comes up pretty close. We don't have quite a big of a gap as we did originally. Um, but I need to switch that class for that date. I'm going to change it to the 8th, which is on a Wednesday. It's the day before. Um, as I always do, I record all my lectures. So if you can't attend, I totally understand. Don't worry about it. I'm switching this on you at the last minute, and I hate doing that. But I'm going to switch it to the 8th, and I'm going to do it a morning class. I'm going to do it at 8:30 in the morning. I know it's probably early for some of you. Um, so if you can attend, great. If you can't and your schedule's already set, I totally get it. I will have it recorded, and then you can, watch it at your convenience. You can even watch it at the next day at 12:30 if that's your normal time for class. So I apologize for that. I try not to do that, but like I said, I had something come up that I have to attend. As a reminder, the 27th of April is the due date for everything. So we need to try to get everything done. It's kind of crunch time. We'll have this lecture and then one more, and then you'll have the test on section 2 as well as your module to hand in. Okay. Any questions on that from anyone? I should say questions or complaints. All right. Awesome. With that out of the way, then we're going to go ahead and get into our lecture. Let me get the slides going, and we'll get moving here. Okay, can you guys see my slides? Yeses? Okay, I'm seeing yeses. Awesome, perfect. Let me get you guys to where I can see it a little better. Okay. All right. So this is section 2, and this is part A. This is going to be myocardial perfusion. I'm excited for this one. This lecture kind of covers probably the big bulk of what you do from day to day in nuclear cardiology. A lot of the other tests we need to learn and pass for boards are ones that we see more periodically, but the actual nuclear or cardiac perfusion stress testing is the main thing. So I'm excited for this one. This one you guys have probably have a lot of questions on and have probably had some experience so far in your clinical sites doing some stress testing. So I'm excited to get into it. This is a fun lecture. Like with all my lectures, please interrupt me. I will get yakking probably, especially on this lecture. I'll just keep yakking. So please interrupt me if you have any questions. Also, this tends to be definitely a lecture that can take up the full 2 hours that we have. So again, if we're not done by the time it's time to go to your next class and to be done, don't worry, everything's recorded. You can leave if you want to, and get out of here. I don't want you to miss Brandon's class, which I believe you have next. Is that right? You have Brandon next? Yeah, okay. So don't shortchange Brandon for me, all right? So hopefully, but hopefully we'll be pretty close to that 2 hour mark. So, all right, let's get into it. So the first kind of question I want to propose to you to kind of set things up or to get talking about the difference of things that we've already learned is we talked about cardiac blood pool and the gated imaging that we do with that. And so the question I have to propose here first is what's the difference between cardiac blood pool and myocardial perfusion? Who wants to take a shot at that? What's different here? How are we imaging the heart differently?
Um, so for a cardiac blood pool, we're looking at the blood going in and out of the heart because we're tagging the actual red blood cells versus the myocardial perfusion. We're looking at the blood going to the heart through the arteries around the heart. So we're getting more of an outline of the heart versus the inside.
Okay, I love that. Thanks. Was that Ashley?
That was, yeah.
Thanks, Ashley. Thanks for being brave, participating. Yeah, you mentioned that with our blood pool, we're imaging the blood going into the cardiac chambers, right? It's going through the heart. We're looking at the volume that the heart is able to push out. We were looking at counts inside the left ventricle, and then the counts that had been that were out of the left ventricle when we had an ejection fraction or we had a squeeze, right? And so you're exactly right. And then myocardial perfusion again is the blood flow that goes through the coronary arteries and then perfuses into the heart muscle itself, right? If you think of the actual word myocardial perfusion, myo is muscle, cardial is the heart, and perfusion literally means blood flow or flow to a muscle or an organ, right? So it's myocardial perfusion. And so with our imaging, what we're going to see in the end is we're going to see, like you mentioned, that we're going to see perfusion or counts that are coming from within the heart muscle itself. Okay. And that's what comes through the coronary arteries. Now, we often have patients ask us, they may have a stent or they may have some previous issue they can see. And often patients will say, hey, are you going to be able to see my stent? And again, no, because we don't image the coronary arteries. That's going to be done getting an angiogram. But we actually view the end product of what those arteries provide, which is the heart muscle and what areas are perfused and if there's areas of the heart that are not perfused. Okay, so that's what we're looking at today when we talk about myocardial perfusion. When we talk about that, we still need to talk about the coronary arteries, especially from our understanding of the pictures that we're going to create. One of the things that happens when you look at myocardial perfusion studies is you're going to be able to see where blood flow is in the muscle and where it's not. The convenient thing for us, of course, is that everybody's coronary arteries just like every other part of our anatomy, are generally the same. Obviously, anatomy has small differences, but they're very much the same. And so, understanding what coronary arteries feed what portion of the heart muscle is important as we start looking at images, so that when we look at an image and we see that the heart is missing blood flow in a certain area, we can identify likely what coronary artery is involved with that process, and where you probably have some kind of blockage or narrowing in the coronary artery itself. So what I want you guys to know for this class in terms of anatomy is three main vessels, okay? And so if we look at kind of this simplified picture over here, and technically I'll say there's technically four main, but three main are the kind of the ones you focus on when we talk about nuclear cardiology. You start off coming out of the aorta, kind of on that left side. You're going to have what they call the left main. The left main is separates into the circumflex and the left anterior descending. So the left anterior descending kind of splits off, and it comes down kind of across the anterior side of the heart, and then it swings kind of over septally. And I'll show you a little more detail on that. But that's the LAD, or the left anterior descending. And then we have the circumflex, which comes off and kind of around kind of the anterior, or excuse me, the lateral and then posterior side of the heart. And then the right coronary artery that comes off of the aorta on the right side, and that's going to feed your septal side of your left ventricle, and then also the right ventricle. And then you'll notice on here that you have other branches that come off. For example, right here we have the right marginal branch. We're not necessarily going to have you focus on those. I just want you to know the main coronary arteries. When cardiologists read things and stuff, they may make assumptions about some of these smaller arteries, but when we look at our imaging, when we look at what our camera provides for us in terms of processing, we're going to be mainly thinking about those three main areas: the LAD, or left anterior descending, circumflex, and then also the RCA, or the right coronary artery. Okay. So let's talk about what areas those supply. The LAD, and what I've done here is I've found a graphic that shows the actual coronary arteries, and then one that shows the ventricle lying kind of in the same plane. And so you can kind of get a visualization of where the ventricle lies and where those arteries are. Now, again, I'm going to point you to the fact, and I've said this before in this class, but in nuclear cardiology, we're really focused on the left ventricle. We're not really focused on the right ventricle. And so everything that we talk about here, especially when we talk about perfusion, it's all going to be centered around that left ventricle. So when we talk about these coronary arteries, I'm really talking about from the perspective of what's feeding the left ventricle. Okay. So the LAD is the main artery that feeds most of the part of that ventricle. So it comes off, and it does kind of like I mentioned, it comes off, swings kind of to the anterior wall of the heart, and then kind of swings towards the septal side. And that's what you're seeing here. It comes out towards the anterior of the heart and swings over here septally. Now, on this image where we can see the artery, keep in mind the left ventricle is mainly over here. So that's why I say it comes off anterior, then swings septally. Notice it doesn't come over here to the right ventricle. If you look here just at the left ventricle and kind of visualize those two on top of each other, you can see that it comes off anteriorly and then swings septal. Okay. This is the one that they call, if you hear people talk about the widowmaker, if you lose your LAD, you're in serious trouble, because again, what do we care about in terms of getting heart or getting blood flow to the rest of the body? We care about the left ventricle. And so this is kind of your main supplier of the vast majority of the left ventricle. And so when we lose our LAD, we lose a big amount of blood flow to the left ventricle. And again, that's why it's called the widowmaker. You will hear some people refer to, I'll go back to the left main as the widowmaker. It's really the LAD again when we're talking about that whole left ventricle. But as you can imagine, if you lost your left main, then it's going to cut off the LAD and it's going to cut off the circ. So certainly huge problem there. And I've actually seen a couple of different sources and textbooks that have said the left main was the widowmaker or said the LAD. I wouldn't worry about it too much. But when you hear people talk about the widowmaker, that they're likely referring to the LAD. Okay. The next one is the circ. This is the circ, also comes off that left main where it branches. It's going to go kind of lateral to the lateral wall, and then it swings posterior as it gets up underneath the kind of backside of the heart. So swings lateral and then posterior. So it's on the posterior lateral wall of the ventricle. And I try to give you a kind of a lateral view of the ventricle. So you can see here that it swings out towards the lateral side and then comes down to the posterior. That's kind of where it's feeding, and then swings around that backside. Okay. And then the RCA, its branches do supply the right ventricle. So I put the right ventricle on here. You can see that's kind of your main supply over to the right ventricle, but it also is what's in charge of feeding that septal wall. So again, if we're looking at the left, we're talking about this septal wall, right down the middle, that muscle that goes right down the middle. That's going to be mainly supplied by your RCA. Okay, so there's your RCA. And then this last one's just another picture that's the same information you have on there, but it kind of just color coats the heart, looking at it all together, where you can kind of get another supply. Again, the reason this is important is when we start looking at pictures of where we have perfusion and where we don't have perfusion, all of the lingo in nuclear cardiology and what your cardiologist or your radiologist, whoever reads it, they're going to refer to these areas. So they'll say we have a defect, which means missing blood flow in the left anterior or the left apical side of the heart. They'll use these terms, and we'll get into those terms a little later in the lecture. But it's important for you to start to kind of understand where do these coronary arteries feed, and what areas of the muscle can I expect to see, so that when we look at images, we know what we're looking at. Okay. All right. So the other thing we need to talk about is the cardiac anatomical planes. And this is the second thing that really feeds into the idea of being able to know what you're looking at on your picture, is understanding how the heart sits. And I've mentioned that in this class as well. But the heart sits a little bit different than the rest of the planes. So you guys are used to, your coronal, sagittal, axial type views when you're looking at imaging, right? And that's how we break up the body. The heart just sits a little bit different in the body, and so it has to have its own anatomical planes. But when we talk about, I've mentioned before, if you view that left ventricle as a cup, right? So it's a cup. And the bottom of the cup would be your apex. So that's down here on the image, your apex. Top of your cup, the part you would drink out of, would be the base. So you have the apex and the base of your heart. And the way that sits in your body is that it kind of sits where the apex is a little anterior. So the apex comes out a little anterior, and the base goes a little posterior. But then the other difference is that the actual heart is turned slightly to the left, so that the anterior wall of the heart is slightly to the left. Okay, so it's almost like it's at a 45-degree angle. So the anterior wall of the heart does not sit to the same plane as the anterior, say the wall of your chest is anterior, right? So it's going to be slightly turned, almost like a 45. So turn to a 45, apex to the front, base to the back. Okay, and so because of that, the heart is kind of given its own anatomical planes. And when we look at images, we refer to the heart in these anatomical planes, not in the normal anatomical planes. So let me give you there's kind of very similar to how you have your I mentioned sagittal, coronal. These are kind of very similar. We're going to slice the heart in different directions, and that's going to be our anatomical planes. So the first one we'll teach you about is the short axis. Okay, so the short axis is going to divide the heart up, and it's going to slice it from apex up to base. Okay, from apex to base. This would be the most similar to an axial view. If you're looking at a CT scan or something like that, the axial view, goes from inferior to superior. And so this is very similar, and they're going to call that the short axis. The next separation, maybe I'll put this next picture on here too, so we can kind of get what we're looking at. But the next separation is going to be your vertical long axis. Okay, so this vertical long axis is going to slice from the lateral wall to the septal wall. Now, I could have said lateral to medial. Notice I didn't do that because, again, we're talking about left ventricle. We're going to talk about our lateral wall and our septal wall. If we went past the septal wall, then we're into the right ventricle, and that could be a totally different way of describing that. So lateral wall to septal wall. this is going to be very similar to like your sagittal cut, right? In your normal X-ray anatomy. And then the last one is the horizontal long axis, and this is going to slice the heart from the anterior wall to the posterior wall. So slice through. So this would be very similar to like your coronal slices. Okay. And so then when we take those images and we slice and we put them up to where we can view them when we're looking at when we've created a study and when the cardiologist or radiologist is looking at it, they arrange these in the same way that you would, just like if you've looked at a CT. So if you look at a CT in the axial plane, it's always going to have the anatomically correct. So it's always going to have the left on the left side, the right on the right side. You're going to have inferior and superior, and then you're always going to have the anterior to the top and the inferior to the bottom. So if you've looked at CT at all, it's the same way we're going to do here, but we're going to have these slightly different terms. So again, if we take our short axis, and I've tried to color label these the same. So if we took our short axis, which is where we're cutting from apex all the way through to the base, and you're going to end up, if you can imagine, you slice that up, you're going to end up with what looks like a donut. And the way that we view that slice, that axial slice or that donut is, again, anterior is always going to be anterior. So the anterior wall is aimed up. The inferior wall is down. The lateral wall, again, because it's to the left side of the patient, is going to be on that left side. And then the septal wall, being towards the right side, is going to be on the right side septal wall. So that's how you're going to view this, okay? So in the axial plane, we've got anterior, inferior, lateral, and septal, okay? So then if you look at the next one, which is the horizontal long axis, if you slice that one and you go from anterior to posterior, you're going to end up looking at just the left ventricle, and you're going to end up with what looks kind of like a horseshoe. And the way that they've arranged that, again, when we're always trying to keep things in the correct anatomical planes, even though the heart is slightly different, what you're going to notice is on this view, and if you were to take this, so this is like doing this. Okay, so if I had that heart and I put it up, and that's your axial view. So you've got anterior, inferior, septal, and lateral. Then what you're doing with the horizontal long axis is just flipping it down, and then you're slicing through that way, okay? And the reason that they do it this way, it would seem like weird, like why not just leave it up the way that the heart has the anatomy? It's because they're trying to make it line up with images so that all images have planes in a similar spot, just like you would with a CT. So the lateral wall, you'll notice, is still lateral, and the septal wall is still septal, but now because we have it flipped a different way, we have the apex at the top and the base at the bottom, okay? So septal, lateral, apical, and basal, the base. When we go over then into the vertical long axis, which slices from the lateral wall towards the septum, they're going to do the same thing. They're going to try to keep the walls that we can view in that plane in the same anatomical area. So now you've put the anterior wall anterior, the inferior wall inferior, and that puts the apex over to the right side and the base to the left side. So this can be really a little bit confusing when you're first looking at this, especially when you're used to the sagittal coronal axle, because they take that heart, which is shifted weird in your body, and then they're going to slice it up, and then they're going to try to make it line up or match with what we would be used to seeing on, say, like anything that produces slices like a CT. Okay, so this took me a minute when I was a student. I'll admit to kind of get what I was looking at. I would look at this and think I had it, and then I would look at a scan that we created, and I'd be like, okay, wait, which wall is what? And it took a minute. So take a look at this, try to get it in your head. Again, remember when you're looking at these pictures, they're always going to try to keep lateral, lateral, and septal, septal, anterior, anterior, inferior. And that usually helps. But again, understand that even though if you try to think of what's in your chest, you think of that heart, and then you try to translate it straight over to these images, it can get a little confusing. So do some study of that. It'll come as you look at images, especially more and more and more. Any questions on that? Okay. So what we're going to do now, so that kind of gives us a base of some anatomy things and what we're looking at and anatomically what we're looking at and what we're trying to produce. What I want to do now is I've kind of separated this out into steps. I'm first going to talk about the radiopharmaceuticals that we use, and then we'll get into how do we actually stress or exercise a patient. And then from there, once we have those two things built, it will make a lot more sense of why we do the protocols the way we do, knowing how each radiopharmaceutical acts, and then also understanding how we create stress and what we're actually even after when we stress a patient. And then so protocols will come last, and then after that we'll kind of get into looking at some images and some of the pitfalls and things that can happen. Okay. So the three that I'm going to cover, and there are lots of radiopharmaceuticals out there. These are probably the three you're likely to interact with. So I'm going to cover thallium. I'm going to cover two tech products. One is Sestamibi, which the brand name is Cardiolite when we talk about using it for hearts. And then the other one is tetrofosmin, and it's called MyoView. Its brand name. Now, I will say from the outset, you guys are actually the last group of students that has to learn about thallium. You're not going to see thallium very much. It's not used that much. Sometimes when there's technetium shortages, you'll see thallium used. However, for you guys, it is still on your test, and so we're gonna keep teaching it. The other thing is honestly, because thallium is like the OG of radiopharmaceutical for hearts. A lot of the lingo and understanding how things work and why we do protocols the way we do was based off that original idea with thallium. And so it actually is, I think, good to be able to understand and learn thallium so that you can kind of build on that and things will make a little more sense from that. So hopefully we do that as we're building this. But most of the time, and likely what you've seen in your clinicals is either Cardiolite or MyoView. Probably Cardiolite. I see MyoView less than I see Cardiolite. And so we'll get into those. All right. So first one is thallium. And I'm just going to go through kind of all the characteristics because it's how we do protocols with these different radiopharmaceuticals is kind of dependent on how they function and how they work. So that's why I want to talk about how they work. So thallium is cyclotron produced. So again, bombarded with a bunch of protons. So it's proton rich, and it decays by electron capture. Now I'm going to ask for a brave person. And you need to know what electron capture is for your test. I guarantee it. So who can tell me what electron capture is? Who's brave? Who remembers? Or even just wants to like go on a limb and just try it. You won't be judged. What's electron capture?
Isn't it when the nucleus grabs one of the inner shell electrons and brings it in? It's when it's like really positively charged, right?
Yep. Who was that? Jesse?
Yeah.
Excellent. Nice being brave. Thank you. You are exactly right. You have proton rich. That's why it's positive. You mentioned positive. So you have a proton rich nucleus that needs to get rid of some of that positive or equal it out. So it's going to reach up and grab that K shell electron. When it grabs that K shell electron, it brings it in. It makes things happy in the nucleus. But you end up with characteristic X-rays happening, right? Because that K shell now has to be filled. And so you get a cascade of electrons coming down a shell. And when that happens, that gives off characteristic X-rays. You'll notice on here, the reason that that's interesting, especially with thallium, is that you'll notice here that the energy range of thallium is 69 to 81 keV. That's low. Think of tech. Tech is 140. So this is a lot lower. And what you'll notice here, 88% of the emission that comes off of thallium is actually characteristic X-rays. Gamma rays, which have a 135 to 167 keV that comes off, it's only about 12% of them. So this is interesting because this is, I think it's one of the only times in nuclear medicine that we actually use characteristic X-rays to image. When you put thallium under a camera, your window is usually set to grab those characteristic X-rays. And you might think, well, why not grab this 135, 167? That's a much better range for our collimators, but it's only 12%. So if you only accepted that, your patient would be under there forever. You're just not going to get the count richness that you need. And so you end up actually viewing these characteristic X-rays. Now, one thing, if you've ever seen thallium, you'll know that it's not the greatest image. And again, as you can imagine, with energy ranges that are that low, even our normal collimators, our low energy collimators, they're just a little bit too dense for that energy range. And so thallium just doesn't produce the greatest pictures because we're fighting this idea of I don't have great energy range to use, but if I use the higher energy range on thallium, then I don't have enough of it, right? And so not the greatest imaging with thallium, and and that's why kind of a unique situation. The other thing I want to highlight here is thallium has a 73-hour half-life. So as you can imagine, that's pretty long. Come all the way down to the bottom here, you'll notice patient dose, 20 millisieverts. Again, it's pretty high, and that's because it has this really long half-life. That long half-life, however, is going to play into stuff we can do with thallium that we'll talk about in a minute here. It's a potassium analog, and so it crosses the cell membrane using the sodium potassium pumps. Um, it's also an it's also distributed in the myocardium proportional to blood flow. I highlighted that. You're going to notice that with pretty much most of these imaging radiopharmaceuticals that we use for heart. We need it to be proportional to blood flow, right? Because that's the thing that we're measuring. We want to see how much blood flow is in an area of the heart muscle. And so if it's proportional to the blood flow, all we are going to be able to see, we don't actually see blood when we take our pictures, right? We only see counts, and the counts come from our radiopharmaceutical. So it's important that proportional to blood flow idea is very important so that we can look at areas of the heart that are missing or that are reduced and be able to obtain that information by use of counts, right? And so it's proportional to blood flow. It has about an 85 to 90% extraction efficiency, which just means that when it goes in the heart, it's extracted into the muscle really good. Whatever passes through the muscle is extracted pretty well. However, only 3 to 5% of the dose is localized in the heart, right? So you get some circulation. So normal distribution here is going to include some GI, skeletal muscle, and kidney. So you'll see some of that, okay? And don't let those two confuse you. It's really good at getting in the heart muscle, but that's saying the portion of it that goes in really well, but there's still circulation through the body. Okay. Now, thallium does something that's really unique that no other radiopharmaceutical does, but it can do what's called redistribution. So when you inject thallium into your patient, thallium goes into the patient really quickly. It goes in, like I said, very fast. It stays in the cardiac muscle for about 10 to 15 minutes, and then it will actually wash out of the muscle and go back into the circulation. And then that cycle can be repeated multiple times as that 73-hour half-life goes. So it tends to go in and out of the heart muscle. And so that redistribution is going to be important later on. In our next lecture, we'll talk about something called hibernating myocardium, and being able to look and see if there's heart tissue that isn't perfusing well. This will help us look at that. And so we'll talk about that later. I don't want to confuse you too much, but it redistributes. That's an important thing to know as we're doing protocols. And then clearance comes from urinary excretion, and the biological half-life because of that urinary excretion comes down to about 55 hours. So we went from 73, which is our physical half-life, down to 55 biological. So again, it still stays in the body for quite a long time, and that's why we get this high dose. Typical dose ranges are around 3 to 4 millicuries. Again, that probably changes based on protocol and where you're working, so don't marry yourself to that too much, but 3 to 4 millicuries. And the likelihood is you may or may not even use thallium much, but that's the idea of thallium. Okay, let's talk about tech sesamibi. This is the same sesamibi you use for a parathyroid, and we call it cardiolite when we're in the cardiology world. And so this is probably the one that I would say the vast majority of you are using. And so this is molybdenum generator produced. Why? Because it's tech, right? You guys know that tech's produced from a generator. It decays by gamma emission, which you also know by now, and you know it has a 6-hour half-life, and you know it's 140 keV. If you don't know those yet, you need to know those. So, but I imagine you do, just from being in the nuc med department, you're going to know that. So this one is not extracted through sodium potassium pumps, but rather the myocardium. It will bind to cytoplasmic mitochondria. So the mitochondria in the cells eat up eat up the tech and they pull it into the heart. Again, distribution is proportional to blood flow, super important, right? So that's good. This has what they call a 60% first pass efficiency. It means that of that first cardiac cycle that goes through and past the coronary arteries, it can get about 60% of it into the tissue right at that moment. Okay. And so it goes in pretty well, and it goes in pretty fast. You'll notice that if you give your patient Cardiolite and you hurry and get them under the camera, you're already going to be able to see it in the tissue on your kind of your monitor screen, right? It gets in there fast. It's not something that needs a ton of circulation. It does not redistribute, right? So again, thallium's the only one that does that. Normal distribution, of course, is going to be heart. You'll probably see this in the liver, GI, thyroid, and parathyroid. Remember, sestimibie is the same thing used for parathyroid. So you should see it there. Hepatobiliary clearance can take 45 to 90 minutes. What does that mean? When you give that, it's going to go to that heart muscle, but it tends to also be attracted to GI, which is your stomach, bowel, and then also your liver. Okay, so it's going to be in there. And it takes about 45 to 90 minutes to clear. Now, I mentioned we don't have redistribution from the cardiac tissue. So once sestimibie gets into the cardiac tissue, it's going to stay, which is awesome. It's going to lock in place. But if you're imaging immediately, you might notice that you have liver and gut bowel uptake. And so again, waiting 45 to 90 minutes will clear that out, and you'll still have your uptake in the heart. And so that's what that's talking about, that hepatobiliary clearance. And that's going to be important when we start talking about protocols and why we do what we do when we image. Because that stays in there, delayed imaging is possible. Remember, I talked about with thallium, it goes in and out and in and out. And so with this, it goes in and stays. And so delayed imaging is possible. Excretion is primarily biliary and renal within 24 hours. This brings the biological half-life, as you know, of tech down to about 3 hours. Okay, so the average patient dose, this really cuts it in half from thallium, which is awesome. So a much better, also I guess I kind of skipped over this, but again, energy range of 140 keV, right? So you're going to get better images out of this in compared to thallium, because we have that energy range that our low energy collimators are just kind of designed for and they love, right? So you're going to get much better imaging with a tech-based product and a lower patient dose. All right, so the third one, which is called tetrophosphate, or MyoView, you'll hear it called. And you're going to notice on here, it being a tech product, most of this is the same as the Cardiolite. It's just slightly different, made from a different company, right? And so you often will see this one, but again, it's molybdenum produced, decays by gamma, 6-hour half-life, 140 keV range, goes into the myocardium the same way through the mitochondria. Distribution is proportional to blood flow. Studies have shown that the first pass efficiency is a little less on MyoView. And there have been some studies that have come out that said that MyoView can underestimate slightly myocardial blood flow at high rates. Why does that matter? Well, when we stress a patient, you're going to have a higher flow rate, right? Because everything's vasodilating and opening up. And so that can underestimate, they found. Again, I've heard of places that still use it, and it's probably not that big of a difference, but there were some studies that came and showed that. Again, doesn't redistribute. The distribution throughout the body is the same as Cardiolite. Hepatobiliary clearance on this one tends to be a little faster. On sestimibie, it was 30 to 90 minutes. This one's closer to just kind of that 30 mark. It goes out. It tends to go out faster, so that could be a benefit. Obviously, delayed imaging is possible. Biological 3-hour half-life and same dose, because it's the same radioactive pharmaceutical. Okay, so there's your 3 pharmaceuticals that we're going to cover. Any questions on pharmaceuticals on any of those? I'm looking at the chat. I don't see anything in the chat. You guys are all asleep today. No, I'm just kidding. All right, perfect. Okay, so before we get into talking about how we stress a patient and what we do in terms of exercise or pharmaceuticals, I want to ask this question, because it will help kind of set up the discussion that we need to have around exercise. What is the difference between ischemia versus infarct? What's ischemia? What's infarct? How are they different?
Ischemia is just blocking it slightly or to a certain degree, whilst infarct is going to be like 100% occlusion.
Okay. Is that Jesse?
Yeah.
Thanks. Thank you. Yeah. Yeah, you're exactly along the right path, Jesse. Ischemia, we might call a reduction in blood supply, which is basically what you said, right? You have a reduction. So think a reduction in blood supply. And then myocardial infarct is, you mentioned the occlusion or the full blockage. What I want you to understand from that is, yes, full blockage resulting in dead tissue from lack of perfusion. So when you say someone has an infarct, usually they're talking about that stage where that heart muscle has died because of lack of blood flow. However, you can also have more of like an urgent situation where they'll say he's having infarct right now, which would mean more of like that urgent blockage. You'll hear them say STEMI in ER. They'll say they're having a STEMI, which means they're having ST elevation myocardial infarct. That's what STEMI stands for, and that just means that they're having some sort of new total occlusion. And the idea is if that's not taken care of, that's what's causing the immediate problem. We'll have dead tissue. And so there's kind of those two things. When we talk in nuclear cardiology, especially when we're talking about imaging, we're not in the ER dealing with someone that's having an immediate STEMI, right? What we're dealing with is the possibility of, do you have an area of your blood flow that's missing or gone? And for us, not being in an emergent situation, that would mean dead tissue. Okay. So when you think of those two terms in terms of imaging, ischemia, think of reduction in blood flow, and we're going to define that one even a little more. And then myocardial infarct is complete missing area or dead tissue. Okay. The other
Quick
one,
question on that.
yeah,
Um,
go for it.
how long can the myocardial tissue make it and be like still viable without perfusion?
Um, that's a good question. I don't know the exact answer, but what I will tell you from us in terms of for us is your tissue can look infarcted because it will lose motion. So in other words, say someone comes in into the ER and they put them on EKG because they're having chest pain and they see something that looks like infarct. What that means is that that portion of the tissue is not contracting and moving. It's lost its kinetic wall motion. You can still have it getting blood flow, but it's super, 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 super low to where it's so low that it doesn't have enough for the sodium potassium pumps to create the gradient for contraction. So I don't know the exact answer to what you said. I would have to look that up. But the other one is important for us in what we look at because we're not always just looking at complete dead tissue. There's always a possibility that what we're looking at is really, 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 really low blood flow, and we're going to account for that as part of what we do. So I probably didn't answer your question fully, Jesse. I'll have to look that one up. I don't know. That's a good question.
I'll take a look and see if I can find it.
Yeah.
I'm curious.
I'm going to write that down because that's a curious question. I don't know. But Jesse, it does lead right into this next thing that I wanted to tell you about, which is what's called hibernating myocardium. We'll look at, in our next lecture, we'll talk more specifically about hibernating myocardium, and we'll talk about viability imaging. But the question with what myocardial or hibernating myocardium is it's one of those areas I was referencing. It's hypovascular, and usually that's from repeated ischemic events where things have gotten low or there's been issues. And again, what's happened in that is it's lost its kinetic wall motion. And so it appears to be infarcted on every general test you can do. But the question is it really, or is it just low blood flow? So in other words, it's alive, it's not dead, but it's lost all it's looking like it is. Okay, and that's called hibernating myocardium. And when we do viability tests, which we'll talk about, like I said, next time, we're about the only ones that can assess whether myocardium is live and just lost its tissue. And then the question is, or excuse me, lost its kinetic motion. And then the question is that area worth revascularizing? Do you go up to the cath lab and try to find a way to get that blood flow back and restore the wall motion, restore the kinetic activity? Okay, so that's hibernating myocardium. other two terms that I want you to think about are the term stenosis. So stenosis is an abnormal narrowing in a blood vessel. And that abnormal narrowing can be any cause. It could be, you could call stenosis, you could say that a vessel is stenosis if it has a buildup of the calcium or plaque, but you could also have some sort of an anatomy pushing on a vessel wall, you could have a tumor, you could have who knows what. Stenosis just means abnormal narrowing. And then atherosclerosis is when we talk about the actual buildup of calcium and plaque inside the artery walls, okay? So atherosclerosis is what you think of when we think of heart disease. And so those terms can be confusing, and sometimes they're used interchangeably, even though they're not completely interchangeable. But if you're talking about coronary artery disease and you say this vessel is stenotic or it has stenosis, you're implying that that's from atherosclerosis. So just wanted to make that definition. So here's why this is important, and this is exactly what you said, Jesse. So if you look at normal myocardial blood flow, it'd be all open. Ischemia is a partial occlusion, and then myocardial infarct is complete occlusion, right? Something's been occluded, and in our case, it's dead tissue. Let's see, where did I put? I thought I had one more piece on that slide. Okay, and so we're going to talk a little bit in a little while of how, when we get to the imaging part, there's some nuances with this. The general idea is understanding these principles, but we're going to get slightly nuanced when we do the imaging. So I'll kind of refer back to this probably when we get into that. I want to talk about, I mentioned a minute ago, ST elevation when we look at on an EKG. And we went over this when we did the EKG, but this is where I want to bring it back now that we're talking about it. When we're talking about ischemia, some sort of reduced blood flow, what you're going to see is the ST segment on an EKG is going to be reduced. You're going to have depression, right? They call it ST depression. And that's what you're seeing here. So ischemia on an EKG, you're going to have that ST depression. And then when you have infarct, you're going to see ST elevation. Okay, so that's why I mentioned before, when you're exercising a patient, these are two things to look for. And again, I know a lot of you probably have an EKG tech coming in and running this section of it for you, but it's still helpful for you to recognize these things, because again, these can be problematic with your patients when you're trying to exercise, especially the infarct. Okay, let's talk about stress testing. Okay. I swear I had another slide in there. That's weird. Do you guys have a question? Do you guys have a picture of an EKG in your? Did any of you download the PDF? Maybe you didn't.
I don't have that.
I looked at what you uploaded earlier, and you did have a whole page of just
It's an EKG, right?
just EKG, but I thought it was later in the PowerPoint.
Maybe it was. I thought that I had it right here. And I also thought I had one more graphic here, but maybe I didn't. Weird. That's all right. We'll get into it. It's fine. We'll cover everything. All right. And then it looks like, let's see, Ashley. Ashley had a text in here that says 30 minutes of true infarct causes irreparable damage. Okay, cool. Thanks, Ashley. So there's your answer, Jesse. Looks like 30 minutes of true infarct. But again, like you said, true infarct as defined, it's hard to define. It's hard to really know, right? If you're really getting no blood flow, or if it's just kinetic motion has stopped. Okay, cool. All right, so do you guys want to break, or you want to just keep going? Might be a good time to break.
Quick.
Actually,
yeah. So earlier you were talking about thallium 201, but my texts were under the impression that we don't use thallium 201 much anymore. And I only say that because recently we've had to do a couple of viability on the pets, which is a pain in the butt with making sure their blood glucose is correct. Since the thallium can do the wash in and wash out, that's what people used to do the viability. Is thallium 201 still used routinely, or are most people using pets for viability?
That's a great question, Ashley, and thanks for bringing it back to the front. So yes, thallium is not used much anymore. It's really being phased out because it's just not a very good radiopharmaceutical. I have had, and they haven't been doing as much lately, but within the last 4 years or so, I did still see it used when there were thallium, or excuse me, when there were tech shortages, that thallium would come out. But yeah, it's probably not used anymore. And you may not, depending on where you live and the pharmacy that you get from, you may not even be able to get it anymore. And like I mentioned at the beginning, the only reason I'm really covering it with you guys is because it's on the test. And actually, you guys are the last cohort that ARRT has it on the test. After you guys, the next cohort coming out, it won't even be on the test anymore. So it is like I said, it's the old guard, it's the OG. And again, I would probably kind of disregard it and not cover it because you're not likely to see it if it wasn't still on your test. For the next group of students, I'll be removing it off the slides. I may mention some principles from it quickly, but yeah. So hopefully that answers your question. And I will cover when we do. I will cover on our next lecture. We'll talk about a little bit, as you mentioned, doing. Oh my gosh! I just had a brain collapse there.
That viability for
Yes,
the
thank you, Cal.
vibrating
Yeah,
heart.
doing viability. And so we'll talk when we go over viability, we're going to cover thallium and we're going to cover PET on the viability. We do viabilities all the time at our facility on PET. We used to do them with thallium, so I've done both. We'll cover both, but yeah, viability is moving to where it's strictly just PET. But again, you may live in an area where you don't have PET and don't have access. And if you can still get thallium is really the only other way to do a viability test. So, okay. All right. I think I'll just keep going if you guys are okay with that. There's going to be morally opposed to me keep going, then let me know. If you need a break, I think we'll just try to get through this. Okay. So here's my next question I want to pose to you guys, because now we're going to talk about stress testing and what we're trying to achieve. So the question I have is when we're stressing a patient, and this could be on a treadmill, this could be pharmaceutical, what are we actually trying to achieve? Who wants to be brave on this one?
So when a patient is doing a stress test, their blood vessels naturally dilate and get larger, so they'll receive more blood flow. So we're looking at the difference between blood flow they receive during the rest versus the stress to see if it's repairable damage or irreparable damage.
Okay. So Ashley, thank you again. She's on fire. No, just kidding.
I did 18 alone this week.
Nice. Very good. So the word that you said that I want to highlight here, you said a lot, and all of it's good and true. The thing that we're after when we do a stress test is vasodilatation. It doesn't matter if we're doing it on a treadmill, if we're doing it with medication. What we're actually trying to do is dilate the blood vessels. So when the body is working hard, so from an exercise perspective, when the body's working hard, the heart also has to work hard because muscles are working, doing stuff, and so circulation has to increase, right? To meet that demand, what happens is your body will tell the blood vessels to dilate and open up, and that increases the blood flow. Okay, that increase in the blood flow is what we're after when we do a stress test. We want to dilate the blood vessels. Now, why is that? If you look at these pictures I have down here, what you'll notice first is that you have a kind of a healthy vessel, and then you slowly have a vessel that's building up some atherosclerosis, right? So you've got plaque buildup in here. What I want you to notice is that the blood vessels have layers, right? It's not just one layer is all your vessel is. There's layers to these, and that's what allows them to be able to vasodilate and vasoconstrict. When we start getting a buildup of calcium and plaque, it's within the artery wall. I remember, so when I was probably like, I don't know what, 11 or 12, my dad had a heart attack. And, obviously it scared me as a kid and whatever. And I'm wanting to know what's going on. And I remember I was actually in with him at an appointment, talking to his doctor, and they were talking about bypasses. He ended up having to have bypass. And I asked the doctor, I'm like, why can't you just go in there and roto-rooter it out? And maybe you've had a patient do that, but I asked the same thing. I'm like, why can't they just go roto-rooter it and send it down? And it's because I didn't understand in my 12-year-old brain at the time that it's not a buildup on the outside of the walls, it's a buildup inside the wall, right? And so there's no way to go in there without destroying the wall and again destroying its ability of what it does to be able to take that out, right? And so the reason I bring that up is what happens here, because it's in the vessel wall, eventually that plaque causes inflammation and eventually calcifies. It's where we talk about calcium in the coronary walls. And so it calcifies and hardens down. And what happens when it does that is that vessel loses its ability to be able to open up and dilate. Okay, it loses that ability. And so under a stress condition, that stenosis or that buildup becomes very apparent because under a stress condition, all healthy vessels and healthy areas of the heart, those healthy coronary arteries, they're going to open up and you're going to see an increase in blood flow, and areas that are not healthy are not going to increase. Okay. And what that means then is that you'll have an increase of uptake of your radiopharmaceutical in healthy myocardium, whereas in areas that can't open up and don't dilate, you're not going to have an increase in blood flow. Now, it's super important to understand this from the perspective of looking at your images. What I want you to think about is this. When you do a stress test on a patient and you get your image up and you look at your stress image and you see an area that's missing, right? You've probably looked at them, and we'll look at some. Let's say you're looking at that axial view and you see that donut and you see a chunk of the donut missing. When you stress your patient, you did not take away blood supply. Let me say that again. When you stress your patient, you did not take away or reduce the blood supply in that area. What happened is that you vasodilated and your radiopharmaceutical filled in all the good areas with a whole lot more counts than what's in that area that now looks black on your image. Okay? So that's why I said a minute ago, when we talk about ischemia, when we look at ischemia on our images, it's a reduction in blood flow, not that you've reduced it by stress. The actual blood flow hasn't reduced in that area. What you've done is you've increased everything else. And so that ischemia on your picture is reduced compared to the rest of the heart during stress. Okay. So this is another one of those things that I didn't understand initially as a student. That's important as you're looking at your images. Again, you're not stressing the heart and then taking the blood flow out. You're just simply increasing everything else, and so it's reduced or ischemic compared to what the blood flow should look like with proper dilation at that time. Okay, and as we're looking at images, that will make more sense as we look at a couple different images and what they look like. Okay, any questions on that? Okay, so with that as the background, let's talk about ways of stressing and what we do here. I throw through patient preparation in here when you're doing your test. Patient preparation is really important to be able to get a correct and accurate and adequate stress. And so patients need to be NPO 4 to 6 hours. Waterstrom mentions 2 to 4 hours. I'm not sure why it includes 2 in there. I've never really heard a lot of departments that only go 2 hours. It's usually 4 to 6. I want you guys, as evidence of that, of why I say trust the 4 to 6, not the 2 to 4. Think about, you've all probably done gastric emptyings at this point, right? You do your gastrics for 4 hours and you've literally watched as that stomach has emptied, right? And usually it takes 4 hours. In fact, a lot of people aren't even empty at the 4-hour mark. Some are, some aren't, but at least takes that 4 hours. So at 2 hours, I would bet that most of your gastric emptyings you can see that they're not emptied. So I'm not sure why Waterstrom has that. I don't like that. They did that. I hope they update that. It should be 4 to 6 hours. So nothing to eat or drink except for water. The other thing that we want to do in terms of medications is we want to stay off beta blockers. So beta blockers affect heart rate response, right? They typically tend to lower the heart rate. If patients on beta blockers, it's because they want to bring their heart rate down. And so we're going to talk about how heart rate, especially when we talk about stressing on a treadmill, we're kind of dependent on heart rate to make assumptions of how exercised someone is and whether or not we've got that vasodilation. And I'll be more specific on that in a minute. And so we need to be off of beta blockers because of that effect of the heart rate response. Most medications that are beta blockers, not all of them. So, look into this, look at patients' medications, but most of them will end in an LOL. So if you're looking at beta blockers, it's like propanolol or called Betalol. Usually they'll have that LOL at the end, beta blockers. So that's something that you can look for. The other one is ACE inhibitors or calcium channel blockers. These affect blood pressure and heart rate response. The blood pressure itself can affect your heart rate response. And so usually we try to have them off of ACE inhibitors, especially if they're going to go on a treadmill. The beta blocker and ACE inhibitor aren't necessarily applicable to every pharmaceutical version of stress, but they definitely affect the treadmill. And when we talk about each of these stress options, we'll refer back to that. The other one is no long-acting nitrates. So anything that they have that is that can be a vasodilator. We want to stay off vasodilators because we don't want to already be dilated. If we're already dilated, then we can't tell a difference between a rest and a stress. And then caffeine, they should be off caffeine for 24 hours. Caffeine is a vasoconstrictor. Caffeine binds to the A2A receptors. When you guys were doing your homework for section 1, I had you look up what A2A receptors are. So A2A receptors, caffeine binds to those. A lot of our medications also rely upon the A2A receptors, and so we have to have caffeine out. Regadenoson, which is probably what most of you are using for your pharmaceutical stress, binds to those A2As. And the problem we run into is that caffeine is a pretty big molecule, and it tends to bind and stay bound. And so if you have caffeine on board and then you give your regadenoson, it comes in and it's just a smaller molecule, less binding affinity, and it doesn't work. I compare it to, I've got 2 sons. I've got a 19-year-old son and a 14-year-old son. My 19-year-old son is really tall. He's 6'7". Don't ask me how I had a kid like that. But he's pretty tall, he's pretty big. And then my son's more like my size. And so my younger son, he has a really awesome room. Like he's decked it out with all these cool lighting and he's got his video game there or whatever. And so it's a pretty cool room. So my older son likes to go hang out in there a lot. And if he's in there, Tyler doesn't want him to be in there, the younger one, but there's nothing he can do about it most of the time. And honestly, there's nothing I can do about it most of the time either because he's too big. But it's just think of it in that way, that it's just not going to go in there. Your stress medicine's not going to work if you've got caffeine on board. All right. So let's talk about exercise protocol first, and then we'll get into the pharmaceutical protocols. There are a few different types of exercise protocols out there. I'm covering this most likely one that you're going to use is called the Bruce protocol. If any of you do something different than this, you can let me know during this part of the discussion, but this is kind of like the gold standard out there for stress. So the Bruce protocol, you're going to hook your patient up to a 12-lead EKG hookup. Again, I mentioned when we did EKGs that we don't put wires out on the arms and down on the legs because you can't do that on a treadmill. That's why in nuclear cardiology, you're just not going to see an EKG set up like that. Everything's going to be up on the chest. And so there's going to be some management with wires. Usually you have a module that has a belt. And so, it's important to make sure the belt's on good, that the wires are kind of out of the way of the patient. You don't want them to have an incident on the treadmill. Bruce protocol starts at a slight slight incline. And you start at a walk, and every 3 minutes it gets a little steeper and a little faster. Blood pressure is taken every 2 minutes, and you're gonna inject the radiopharmaceutical at peak stress. Now, we need to define what peak stress is when we say that. So peak stress is defined as 85 to 90% of the maximum heart rate. Now, that immediately makes the question, well, what the heck is max heart rate? So they define max heart rate, and it's determined, you take 220, and that 220 stands for beats per minute. So 220 beats per minute, and you subtract the age in years, okay? And then that's your max heart rate. So let's just do mine real fast. Now I'm going to reveal my old man age to all of you. So I'm going to take 220, and I'm going to subtract, I'm 48, and I get 172. So that would be my 100%. But if I want to know what 85 to 90 is, you could just times that by, I'll just times it by 0.85. Oops. Something went wrong. 220 48 times 0.85. And I get 146. So 146 would be where my kind of peak exercise or peak stress starts, 146. So they would want to do this protocol of every 3 minutes, a little steeper, a little faster until I at least got to that. And then you're going to want to continue exercise for 1 to 2 minutes post-injection. So you inject the radiopharmaceutical at that peak stress, the 85 to 90, and then you're going to want to keep them going on the treadmill at that same level for at least 1 to 2 minutes. Okay. Well, I put a caveat down here. Inadequate stress on a treadmill, the most common reason for a false negative stress test. The false negative we get most often, in other words, we don't get them stressed enough so they don't vasodilate, and the rest scan and the stress scan end up looking exactly the same, and we have a misdiagnosis, or we may have missed something because we didn't dilate, right? And so that can be the biggest thing. So is there a way while they're on the treadmill to necessarily tell, there's nothing on your patient to say, I know that you've dilated. And so that's why they have these other determinants like the peak heart rate and so on and so forth. Now, even those aren't foolproof, but from the studies that have been done in the literature, this protocol's come up, and the tests and study that they've done showed that that if you go to the 85 to 90% and then you exercise for a minute with radiopharmaceutical circulation, that you're going to have adequate stress. Okay. So that's why these protocols are set up the way they are. Now, there's a lot of times that, the other caveat I should put here is you probably aren't going to be running the treadmill. You're probably not going to be the one that does that. You're probably going to be responsible just to have that radiopharmaceutical. Most facilities will probably have an EKG tech come in and kind of run the EKG side, and you'll probably have a PA or a doctor that oversees the actual time on the treadmill. Okay, so there could be up to 3 of you in there. At our facility, our PA comes in and they kind of run the EKG and direct the treadmill while we're just kind of on standby waiting to inject the radiopharmaceutical. So there's like I said, there's caveats with this. This is something you need to try to see if you can, because learning about it is totally different than running it. Again, the patients can, some patients can do this really well, some can't. There's always you're going to have to inject a radiopharmaceutical in the middle of this while they're still exercising at a high rate. That can cause problems. Most patients want to grab onto the bar in front of them as they get running hard, but at some point they're going to have to let go of that bar because we need to do blood pressures every couple of minutes. Also, they're going to need to let go of that bar so that you can inject the radiopharmaceutical, and that can be scary because you can have issues that happen there. I was in a situation once where one of the techs, there was an issue and the patient moved their arm, and it was in the middle of injection and they squirted tech everywhere. And so there was like tech all over the treadmill, and it had gone everywhere. So this is one of those things that when you perform these, you definitely want to kind of have things in the right place. You want to communicate with your patient what's going to happen really well so that they know, okay, now I'm going to take your arm and we're going to inject. And so they kind of know what's happening, just to make sure it flows really well. Okay. Any questions on exercise protocol? Okay. See anything in the chat? So let's go to this one. Oh, we want to talk about contraindications. That's right. This is where my EKG was. I was thinking it was in a different place. Okay. So contraindications to a Bruce protocol to getting on the treadmill. First one we've talked about, and we referenced it when we did EKG, but I'm just going to bring it back to your mind now. And that's a left bundle branch block. Now remember, a left bundle branch block, we talked about blocks between the SA node and the AV node. That's not what this is. A left bundle branch block is the AV node fires off, and then it goes down the bundles, the right and left bundles, and stimulates ventricular contraction, right? And in a left bundle branch block, that timing is really, really slowed down. So there's something wrong in the bundle branches that just slows it really, really quite a bit. And so that's what a bundle branch block is. Now, why can't we run these people on a treadmill? There were 2 reasons that I gave. One of those reasons is that if you look at a STEMI right here, so this is the patient starting to have infarct, and you get this ST elevation. And then this over here is just a left bundle. Okay. And you'll notice that we have a lot of ST elevation. So the determination between a STEMI and a left bundle can be hard to detect. It can be a difficult thing. And then the other problem is as you start running on a treadmill and heart rate increases, it gets to where they get so close that they look a lot like what you see here in V3, where it's like it's up and down, up and down. I mean, it also almost looks like VFib, which is, you don't want your patient having VFib, but it's very difficult to be able to monitor with EKG while a patient's on a treadmill, and be able to monitor what's happening. The EKG just doesn't give you an opportunity to do that because of what it's looking like. The other reason that we don't is we can get what's called a false septal wall defect. Remember, I mentioned that in a block, what you have is those bundle branches that come down to contract the left ventricle. It's a very slowed process. We talked about how the QRS complex is lengthened out, meaning that contraction is happening slower. Everything down there is kind of gone into slow motion. And so what happens is when you think of how the heart beats, the myocardium, it fills at relaxation. Okay. That's when it gets most of its blood flow, is when the muscle relaxes, it allows the blood flow. When the muscle contracts, it tends to push some of that blood flow out of the myocardium, or at least not let more in. And so when you get that septal wall that is really slow, the rest of your myocardium is contracting, and now blood's coming back in, contracting, and that septal wall just becomes very low perfusion during exercise, because it doesn't have a chance to relax long enough to get that slow contraction to chill out enough that the blood flow gets in. And so when you get these patients under the camera and you take a picture, if you did a Bruce protocol and while they were under bundle branch block, it's likely that you're going to have blood flow missing from the septal wall when you look at your images. And you're going to assume, oh, they've got a septal wall defect. There must be a blockage going on in the RCA. Let's get them up to the cath lab. You get them up to the cath lab and they do an angio and there's no problems. Their coronary artery is fine. And again, it's just because it couldn't fill back up because of how that contraction is happening. So those are the two reasons. No bundle branch blocks. We don't exercise bundle branch blocks for those two reasons. Another one that is a contraindication is exercise tolerance. Obviously, when we are doing a Bruce protocol, we're dependent upon getting the heart rate up to a certain level so that we can guarantee we have vasodilatation. And if we can't get up to that level, then we can't guarantee vasodilatation. And now our test is, iffy at best. Medications like beta blockers. This is why I mentioned earlier beta blockers. We need to be off beta blockers because if we're dependent on heart rate, then our beta blocker will keep our heart rate down and we may or may not get vasodilatation based on that heart rate. Obviously, active chest pain. If your patient comes in and they're just like, man, I'm having such bad chest pain right now, you're not going to want to throw them on the treadmill. You're going to want at that point to get a provider, have them assessed, and then go from there. Extreme hypertension can be a problem. So when you're 200 plus on your systolic, that's going to be an issue. And typically blood pressure goes up with exercise because of the tension of the body and working of the muscles. And so we don't want our patient's blood pressure to go through the roof. And then the other one can be tachycardia. If they're really, really elevated, it could be dangerous to get them even more elevated than that. So if they're starting off in exercise ranges of like 140 plus, then that could be an issue. The other issue that you run in there is if someone's really tachycardic, there's a chance that they could be a little bit dilated already. And so that introduces problems into your imaging. Okay. So that's your contraindications. Now we're going to talk about pharmacological stress. So I've included 4 on here. These ones still are currently on your boards. The real reality of this is you're probably most of the time going to be using regadenoson. Brand name that first came out is LexiScan, although there's now generic, so you may have a generic version of regadenoson that you're using. Some of you could see adenosine. When I was a student, we still were using a little bit of adenosine, and then LexiScan came in, and so possibly adenosine. Dobutamine is still used in the hospital, although we don't use it very much in nuclear cardiology. They use it a lot in echo, but it is an option, and then dipridamol. So we'll cover all of those. We're going to start out with adenosine. So the way that adenosine works, and again, keep in mind with all these, what are we trying to do? We're trying to get that vasodilatation. So adenosine binds to the A2A receptors in the cell wall, and it inhibits calcium entry. And so if you get calcium is low, calcium is what brings everything back down. So get an extra potassium there. What you're going to get is the cell wall relaxing, and that causes the dilation, right? So the cell wall relaxes, everything dilates out. Adenosine, if some patients can be on adenosine if they're already on adenosine for something, obviously that's not going to work. They have to be off adenosine before they come. I already mentioned caffeine when we talked about PrEP. So this is the reason caffeine can bind to that A2A receptor and it will block adenosine. So we want to be off caffeine for the 24 hours. The dose for this is 0.14 milligrams per kilogram per minute for 6 minutes. So typically what you have with adenosine is you have a little pump that you have set up and you draw in their dose. And basically what you have to do is you grab this much of a dose and then you have to take in enough saline that your pump goes to 6 minutes so that it will inject slowly over the 6 minute time period. Okay. Radiopharmaceutical is injected halfway into the injection, so 3 minutes in. Usually patients have some pretty significant side effects with this. So those include headache, dizziness, flushing, shortness of breath. They can get a little bit of chest discomfort or chest pain, and you can get AV block that occurs during this. So they're going to be hooked up to EKG when you're doing this so you can monitor that. And side effects occur in about 75% of patients. Now, I will say that I included these last two side effects as things that you look for that can happen. This 75% stat is really applicable to these first ones, not necessarily the chest pain and the AV block. You're not having 75% of your patients with AV block. Those are the ones that just can occur and can look for, but that 75% should be attached to those initial ones. So like the headache, dizziness, flushing, nausea, and things like that they can get, okay? The biological half-life of it is less than 10 seconds. And what that means is that if we get a patient and we, start noticing some significant chest pain or AV block occurring or whatever happening, then the easiest way to reverse adenosine is just to stop the injection, right? Turn off your pump. And because its half-life is less than 10 seconds, it goes out of their system quick and they can start feeling better pretty quickly, okay? So that's what I have here. So that's adenosine. The next one is dipridamol. And basically what dipridamol does is they call it an adenosine diamynase inhibitor. What that means is that it blocks the breakdown of adenosine in your body. So your body produces adenosine, and then it breaks it down when it's not needed. And so what it will do is it stops that breakdown and inhibits it. And so what you get is you get a large accumulation naturally of adenosine building up in your body. And then at that point, it basically works the same as giving them an adenosine injection. Once that's built up, it causes that dilation to happen, okay? So obviously, we don't want adenosine already on board for this one as well. Caffeine needs to be withheld. Another one that really I could put on the other one as well is aminophylline. Some patients are on aminophylline. Aminophylline is another drug that binds to the A2A receptors and is very similar to caffeine in that it will create the relaxation and kind of push everything out. So any of that needs to obviously be withheld, anything that affects those A2A receptors. The way they dose this is they do 5 milligrams per kilograms in 20 to 40 ml of saline, and then you create a rate on whatever pump you're using of 0.14 milligrams per kilogram per minute, and it goes for about 4 minutes. Radiopharmaceutical, instead of being injected on the middle like you would with adenosine, you inject it after this infusion is completed. And that makes sense because, again, the way this works is it stops the breakdown of adenosine in your body. So that has to take time, those several minutes for it to build up and to cause that vasodilatation, right? And so that's why we inject at the end. Side effects, again, are similar with this one because we're just still talking about adenosine. And so you can see usually the side effect profile is a little lower in terms of percentage because I don't know if that's just because it's the natural adenosine in your body versus a big bolus of it externally, but they percentage is a little lower. Plasma half-life is 30 to 40 minutes. So this is different than adenosine in the sense that you can't just stop the injection and things go away. It takes longer for that, the stopping or the breakdown of adenosine to naturally occur in your body again. So aminophylline, that's why I mentioned it with this one, is aminophylline is a common drug used to reverse it because it will just go in and kick the adenosine that isn't built up in your body off of the A2A receptor and make you feel back back to normal again. Okay. Dobutamine. Dobutamine works in a totally different way. It is what we call a beta agonist, and it increases myocardial oxygen demand. So it makes it so the myocardium suddenly needs more oxygen. The only way to do that is your body will have to increase blood flow. And so to increase blood flow, it kicks in all the things like increased heart rate. So this one actually affects heart rate in that way, right? It increases that demand, and then the heart rate's going to go up. And now we're working the same as an exercise stress test. When we've made the heart rate go up, we're going to cause that dilatation to respond, right? Because the coronary arteries, heart's working faster, so it's like we need more blood flow to the heart too. Boom, dilate the coronary arteries. Okay, so in this one, because it's dependent on heart rate, this is another one where we can't have beta blockers, because again, remember, beta blockers slow down the heart rate. So we want to have beta blockers withheld. The dose on this one is you begin with 5 to 10 micrograms per kilogram per minute for 3 minutes. They usually increase the dose every 3 minutes to a maximum of 40 mics per kilogram per minute. We have done dobutamine on patients before that couldn't be on other types of medication. And usually this is done by a PA. Like, I've not been the one that has ever set this up, at least in our department. A PA has. And there's a likelihood that none of you that you may not ever use this one at all as well. But basically what we're trying to do is the radiopharmaceutical is injected 1 minute after that highest tolerated dose and maintain for 2 minutes while the radiopharmaceutical circulates. This one's interesting because it says highest tolerated dose. So they're just trying to get it as high as they can to guarantee the heart rate goes up. And when we say highest tolerated dose, it's because dobutamine generally has some of the worst side effects. It really makes people feel like junk. I've had a lot of patients who have had some other kind of stress test, and I ask them about it. And usually it's like an echo, and an echo, they sometimes use dobutamine, and they'll be like, I hated that. Is this going to make me feel that way? And I'm usually like, no, we're going to be way better. Don't worry. You might get some of that, but not nearly as bad. Because again, they push them until they just feel so crappy that they're like, I can't handle this anymore. And then they'll go. So side effects are high in terms of percentage as well. Biological half-life is about 2 minutes. They reversed this one with a rapid acting beta blocker. Again, beta blockers bring down heart rate, right? So this is dependent upon heart rate. So makes sense that we'd reverse it with beta blocker. This one can have some contraindications when they have pretty severe asthma. It can really exacerbate asthma. And so asthma or COPD, so lung conditions can have an issue here. So those are the ones that they kind of look at before determining whether or not they can give dobutamine. Have any of you seen this used? I know it's sometimes used, but oh, right, someone did. Liz, our facility uses dobutamine, but it's rare. Haven't seen it pushed yet when they've done it. Yeah, that's pretty typical. Pretty rare when it has to be used, and probably not going to see it a whole lot. All right, so now we're on to the golden one, the good old one that you've probably all seen and you've probably all likely used if you've done hearts by now. But that's regadenoson. So regadenoson is kind of like a cousin to adenosine, but they've made it in such a way that we can use it a little more efficiently, and the side effect profile has gone way down from what adenosine was. So it works in a very similar way. It binds to the A2A receptors in the cell wall. It causes that relaxation and opening up of potassium channels, smooth muscles relax and dilate. Again, we want to be off of caffeine of any kind. On this one, this one gets a lot of patients. If you just tell them stay off of caffeine, they don't think of things like chocolate. So you told them to fast for 6 hours for their test, but you told them off of caffeine for 24, but they didn't think about things like chocolate, which contain caffeine. So we've gotten used to in our department telling them you can't take anything with caffeine. Look if there's any kind of caffeine in any medicines you take, and also keep aware of what foods are. And we usually mention chocolate because nobody knows that it has caffeine in it and it can affect it. So I put that one on there. This dose is so nice because with all those other doses, we were using some kind of pump, and these measurements were all crazy and we had to measure it all out and get it perfect. This one's awesome. It takes away all of that. And it's just, they come in a bolus injection syringe. It's 0.4 milligrams of bolus. It's in 4 ml. And for this one, it's just a 10 to 15 second push. That syringe is all ready to go for you, and you follow it by a 5 ml saline flush. So super easy to use. Radiopharmaceutical is injected 10 to 20 seconds after the saline flush. Now, there's some caveat here. You'll see this is on some of the packaging, but the other thing the packaging talks about is that you get peak vasodilatation at around 90 seconds. Now, let me tell you why this, in our department, we've adjusted and we don't use the 10 to 20 second radiopharmaceutical anymore. We go 90 seconds. And I will tell you that this is less important when you're talking about using Cardiolite. Because again, remember, Cardiolite's going to circulate, right? So you give it to the patient, it's going to start that dilating. You're going to get circulating of Cardiolite, and you're going to get that dilation by 90 seconds. So you'll get a good picture still, even with Cardiolite, if you do 10 to 20 seconds. You could wait the 90 seconds, it's fine. When you get to PET, you start, it's a little bit different. And the reason why is in PET, they measure something, and we'll talk about this next time when we talk about PET, but they measure something called myocardial blood flow, which looks at the bolus of your radiopharmaceutical, of the rubidium coming into the heart. And so the reason that we have to wait is because we need full dilatation to get an accurate MBF measurement. And so a lot of times in PET, you're going to see a 90-second delay, whereas you may, if you're just in a standard cardiology department, they may not do that. A lot of cardiology departments, as this information has been learned over the last several years, has gone to the 90 seconds. So that could be a caveat there. I've still listed it as the 10 to 20 seconds, but it could be up to 90. What are your departments doing? Do you know? Are you guys injecting Lexi right after your, or not Lexi, sorry, I didn't mean to say that. You're injecting your, right after the saline flush within 10 to 20 seconds? What are you doing? 20 to 30, Jesse? Okay. 20 seconds, cool, okay. Yeah, I think the packaging mentions this 10 to 20 seconds. So yeah, 60 seconds, okay. Yeah, and any of these honestly are acceptable, especially when you're talking again about using Sestamivir or Cardiolite. PET, you're probably going to see as you go to PET that departments are getting up on this and doing it a little bit different, but yeah, cool. Okay, so side effects on here, shortness of breath, you're going to get a heart rate increase. Those are kind of these two standard that kind of everybody gets. Some people get some flushing, there's some nausea that can happen, headaches happen with this quite frequently, but this one's awesome. You only get about a 30% profile of severe side effects with this. There are some patients that get really severe and they can get so nauseous that they throw up. I probably shouldn't tell you this because it's just an embarrassing story, but I had a patient once that was getting really nauseous, and I had gone back. This was on a PET scanner, so they're in the camera when you give them this, right? And their pictures are happening live, so they've got to hold still. And I went back to her. She's like, I'm just feeling really sick. So I was like, you're gonna throw up? She's like, I think I might. So I'm like, well, give me a second. And I ran over to get a bag so I could put it by her and have her turn her head and go in the bag. And I ran over to where we grabbed the bags and they were out. Someone hadn't restocked them. And so I heard her, she starts going, she starts with the sounds. And so I run back over there. I'm like, I hadn't even put on gloves yet. And I didn't want anything on the camera. And I literally put my hands out. I don't know what I was smoking, but I put my hands out and she threw up in my hands. That was not my finest moment. I don't know if that was like a dad reflex or what. I you know what I mean, with like your kids. I think that's what happened. I think it was a dad reflex because it was the grossest thing ever. Anyway, I get teased to this day about doing that, but don't do that. Try to get gloves on at least first. But yeah, so your patients can have severe reaction to this, but it's less likely than all those other ones. Contraindications. This one's important. Well, I'll mention these two. Half-life 2 to 4 minutes, so it goes away pretty quick. Reversed with aminophylline or caffeine. Contraindications: second or third degree AV block. Okay, so that's when we get a disassociation between the SA node and the AV node. Now, first degree is okay, and if you remember what first degree is, it's where there's a lengthened time period between the P wave and the QRS. But it's still, each P wave is still firing off a QRS, it's just slowed. That one's okay. But when we get to anything where they're starting to get disassociated, and you can go back and look at those blocks, then we can't give Lexi. Now, I understand that a lot of your departments, you're going to have an EKG tech coming in and checking all this out. If it were me, though, I would still be someone that takes a peek at the EKG, tries to see those when they come and get used to what a block looks like, because you could have a new EKG tech that day that came along, and you can cause the heart, you can cause some severe heart issues. You can cause their rhythm to go off. You can cause them to actually go into cardiac arrest if you're giving it to them when they have a block. So it can be scary. We have had a couple of occasions where our patients have been given Lexiscan because somebody missed the block. Luckily, and I cross my fingers, the two of them that I can think of, the patient did okay and it didn't cause a problem. But you just don't want to be in that kind of scenario. So be aware of anything besides a first degree AV block as a problem. And then I put on here relative contraindications. One of those is seizure history. If they have seizure history, they can get this done, but it tends to exacerbate seizure. And so a lot of times if they're on a seizure medication, that will be okay. I've even had patients that they have known seizures, but they've given them seizure medication just beforehand, and then gone ahead with it. Usually if you find out your patient has seizure history, you're probably going to want to go to a provider, like if you guys have a PA or the radiologist or someone to kind of get their direction on that. So it's not something that's a hard stop, but it's a hard stop for you to like stop and figure it out. Severe asthma can be a contraindication. It can also exacerbate asthma. And so a lot of times, if you'll want to ask your patient if they have asthma. If they do, I often say, hey, do you have your inhaler? How bad is it, first of all? And then do you have your inhaler with you? And if they do, you can pre-treat ahead of the Lexi. It's not going to cause a problem for the Lexi, but it's just going to mitigate that asthma issue that could pop up. In our department, we actually have albuterol stocked that we can give to our patients if they need it. But that's one that can pop up easy, is that asthma or COPD. And then again, resolved with albuterol, and the history or the seizure history you can have Valium on board. But again, Valium isn't something that you guys can give as tech. So usually that's why I say you have to get a provider involved at that point. So any questions on Lexiscan? You guys have probably used this one a bunch, I'm guessing. Oh, it looks like I'm not the only one that has caught the vomit. Sweet. I don't feel alone. Highly don't recommend. Thanks, Liz. All right. Okay, now we're going to get into protocols and pictures and try to wind up. I recognize right now I've yacked again. I'm a yacker and I've yacked too long. So again, if you guys need to go at this point, I totally get it. You can come back and look at these and go attend Brandon's class. So do whatever. I'm not your dad, so you can do whatever you want. But if you need to leave, that's totally fine. Oh, and actually, no, I'm wrong. We go till 2:30. Never mind. Scratch that. I should get done pretty close. So sorry about that. I was thinking 2 o'clock for some dumb reason. Okay, let's talk about protocols. Now that we've built up all the stuff we need to know in the background, now when we talk about these protocols, things are going to make a little more sense on why we do what we do. So I'll start out with the thallium protocol, and I'll try to get through this quick because, again, you probably won't use this. But obviously, with every protocol, verify patient preparation. As you can see now that we've went through it, patient preparation is important on these. With a thallium protocol, you're going to stress the patient according to this chosen protocol. And you'll notice that on thallium protocol, we start out with stress, okay? And I'll explain that as we go along. But we're going to stress the patient according to the chosen protocol at peak stress, whatever that stress is. You're going to inject 2 to 4 millicuries of thallium. And then remember with thallium that we immediately get it into the cardiac tissue. You've got 10 to 15 minutes to image because it's going to redistribute. It's going to wash out. So you stress them and you immediately get them on the treadmill. You have to be quick with this, or not the treadmill, the camera, sorry. You stress them, immediately get them on the camera, and you're going to image right away. Patients should be placed supine on a SPECT camera. We raise the arms above the head when we do cardiac imaging because we want to get any attenuation from the bones in the arms out of the way. That can cause things to look like a defect when they're not a defect, so we always want to get arms up. Images are centered over the heart, and we're going to do it in L mode with a 180-degree arc. And usually on thallium, you're going for 20 or 30 minutes. Now, don't be married to any of the times I give you because a lot of that depends on your protocol and also on your camera and the crystals and the configuration. And they're always trying to make these scans faster and faster with the latest and greatest. So, but it's going to be probably in that neighborhood with Valium. Now, this can be done as a stress-only protocol, okay? And the reason that we do stress, I'll kind of finish the what we do with the rest, and then we'll talk about why we can only do stress. But remember, we're going to image right away, and then you're going to get a washout, okay? And so you're going to go through a few cycles of these washout. We're going to bring the patient back in 3 to 4 hours, and we're going to image them again. And we don't need to do anything. We just put them under the camera and image. And what's happened is by that time they've calmed down, they're at rest. And you might be thinking, well, wait, we gave them the thallium when they were at peak stress, and it went in there and locked into the heart muscle and was showing us. But again, this is why this redistribution principle is helpful with thallium, because it washes out and it goes through a few of those cycles. And by the time you come back 3 or 4 hours later, you're going to catch it in a cycle now that's been, your heart is completely relaxed. So it's going to be a stress image, okay? And so there are some departments that when they come back for the rest scan, they'll give them an additional, like, millicurie of thallium to boost it up a little bit. But you can image 3 or 4 hours later with thallium. Again, remember, it stays in our body forever. Not forever, but it's a very long, the biological half-life is 55 hours. So it stays in there for quite a bit of time. And then you can just simply image the rest again and have it at that time. Now, this is important going forward and in a lot of things, but why is it that I could do a stress-only protocol? And when would I choose to do that? Any idea? Why could I do a stress and then be done?
Because if you're not seeing anything being blocked on the stress imaging or any sort of lack of perfusion, then it's not going to be an issue with rest.
Right. Exactly right. If we stress them first, because remember, what we're trying to answer is, can all areas dilate? So if we did a stress test on a patient and we've tried to dilate, and then we've given them we've got adequate stress, and then we give them our pharmaceutical, if the entire heart wall muscle lights up in the same distribution, then we've answered our question, everything dilated. But if we do the stress and we pull it up and now there's an area that doesn't show up, now we have a question, because now we don't know whether that's ischemia or whether that's infarct. And that's really the purpose of a rest. So thallium was the old G, and they would put it in, they would do a stress test, and then they would look at it. And if it was all filled in, you've answered the question of dilation and you're done. And the patient can go home. They don't need to come back in 3 hours. But if there was an area missing, then the question is that missing all the time? Or is it only because that area did not dilate and the rest of it dilated? And we have to answer that question. That's the only thing that's going to tell us whether this is ischemia or whether this is infarcted tissue. Okay, so that's what they're trying to do there. The last thing I'll mention on this slide before we exit is we can do viability imaging because it stays in the body so long. I'm not even going to really go over that because we'll do that next time, but viability imaging can be done the next day. Okay, so let's look at some images here. So this top is my stress, and then just underneath it is the rest. And then we've got all of our different views here. And so what you're going to notice here is with this particular patient, when this thallium was done and they did the stress first, that's the exact scenario that they were in, the one I was just mentioning, that you see that there's distribution here. You're missing something kind of over towards kind of the lateral wall, kind of lateral inferior wall. You've got this missing area of blood flow. And so this patient then would have been in one of those cases where they can't just send him home because now they have to answer, is this ischemia or is this infarct? And so they went ahead and waited the 3 hours. They brought him back, put him under the camera. And now this is our image that we're looking at here. So you guys tell me, is this patient ischemic or infarcted?
Ischemic,
And why do you say that?
because the blood flow returns at rest.
Exactly. The blood flow returns at rest. Exactly. And so the reason we know that's ischemic is because, again, ischemic just means reduced, right? It doesn't mean missing. And so if this was an infarct, then what we would see here, we would see an area that's also missing in the rest. And then we would know that you're right, you're not getting blood flow during stress because there's no dilatation because there's no blood flow. And you came down here and you're also missing it at rest, means it never was there in the first place. And if it was never there in the first place, then it was tissue that was already not perfused, already dead, right? And that's what we define as infarct. Whereas tissue that's able to fill in or be reversed, we define that as ischemia, right? It's just reduced compared to everything else. There's a couple of terms that I want you guys to know. You'll hear the term fixed or reversible, and this is why understanding thallium is important, because it makes sense with thallium. We do the stress first, and if we find a defect, then we have to ask ourselves the question: is this defect fixed or reversible? And what we mean by that is that if we get the defect on stress and then we bring them back for rest and the defect is there, it's fixed. It stayed there. If we have a defect on the stress and it's not there on the rest, then it's been reversed. Now that doesn't make sense when you go to protocols with cardiolite, because we usually do a rest first, and you may have it in a cardiolite. If this were cardiolite, we would have done this rest first and we would have been like, oh, looks good, now let's stress them and see if there's an area. And to say that it was reversible when you're looking at cardiolite is confusing, because you're like, well, wait, I didn't reverse. I got rid of some of the blood flow. I didn't reverse it, right? And the reason they still use those terms, meaning it was reversible, meaning you hadn't want it filled in with the rest. But it just can be a little confusing. So hopefully that makes sense to you. That's why thallium, like I said, the terminology came from thallium, and it makes sense. We had a fix and we reversed it, or we didn't reverse it. So fixed or reversible. Okay, that's what that means. Here's your normal, and then here's the stress test that's fixed. So this fixed one, what does this mean right here? Somebody tell me what this means. What do I have? Infarct or ischemia?
You had an infarct.
Yep. And the reversible, then obviously we have the ischemia. Okay. What questions do you have on that? I want to make sure that you understand. If you're like, wait, what the heck's he talking about? Pop a question out. Let's understand it before we move on to the sesame stuff. Any questions on that? Does it make sense? Okay, I'm going to assume that's a yes, or I'm going to assume you're too nervous to ask me the question. And if you still have the question, send me a message. We'll talk private. Okay. All right. So coming off the back of thallium, when they first started using sestamibi, they kind of stuck with some old ways. And so there's some protocols out there, and there are places that I've seen still use these old protocols. And so we'll talk about a stress rest protocol. It's a 2-day protocol that they use. Okay. So on this, you're going to, again, verify patient prep. And this is a stress first. So you're going to stress the patient according to whatever your stress protocol is. At peak stress, you're going to inject 30 to 40 millicuries of sestamibi or cardiolite, or whichever one you're using. If you're using tetrafosmin, you're going to inject. And then post-exercise, we're going to image the patient. And we're going to image them 30 minutes to 1 hour after injection. Why am I imaging them 30 minutes to 1 hour after injection? Is anybody that can answer that question? You're probably
kind of want. Oh, sorry. You
Go ahead,
kind of
Liz.
want the activity to exit the liver and like so it won't get in your images.
Yep, that's exactly right.
And the bowel.
That's exactly right. And I know probably half of you are not wanting to. Thank you, Lewis, by the way. I know half of you aren't answering that question because you see something different than this at work. And so we'll get caveated. I'm just going to give you what the protocol should be, and then we'll talk about oftentimes what actually happens. But yeah, you're going to wait that 30 minutes, and then patients placed on the camera. And the camera protocol in terms of imaging is going to be the same with pretty much all of these. They're going to be placed on the SPECT camera, arms raised above the head. We're going to attach the 3-lead EKG because these images are often gated. And so most of your places, I'm sure, gate the images, at least the stress image, or at least one of the images. We're going to image over the heart at 180-degree arc in L mode, approximately 25 stops. Usually takes about 10 to 15 minutes. Some of these are much lower now with your cameras. Our camera can do this in about 8 minutes. One of the ones we have. So again, this, don't be married to that, but you're going to acquire that spec. Now, this protocol, when it was first brought forward, was exactly like thallium. The question is, if stress images are normal, then we can omit the rest, okay? And so that was kind of the question. We pull up a patient, it looks good, let the patient go. This reduces the time the patient has to be there. It also reduces the patient dose because they don't have to have a second injection, and just kind of made everything hunky-dory. But that's if you didn't have a defect, right? If you had a defect, well, now you've got to answer the question, is this ischemia or is it infarct? And so that caused the problem. Now with this one, in thallium, they could do it the same day a few hours later because of redistribution. This one does not redistribute. It's going to stay in there, and you've got that 6-hour half-life that's going to make its way down. And so that's why this one had to be a 2-day protocol, because what you would do is you would bring them back the next day, and then that gave enough time for the half-life to decay, for the sesame to decay, and make it so that you didn't see it in your next picture, right? And so then the next day they would come, same thing, inject 30 to 40 millicuries and do the same imaging. So in these ones you have similar dosing. The dosing is the same on the rest and the stress, and you would do the same imaging. Now, advantages of this are that it allows that full 30 to 40 millicuries to be used. Now, I know a lot of you in your clinical sites are probably using a little bit less than that, probably because you have a camera that has some awesome crystals or however they've designed it. But still, this protocol allowed the full dose to be used, and that's going to give you greater resolution and greater counts and a better picture to use that higher dose. And then, of course, we can reduce patient exposure, right? If everything's good, then we can move on. Obviously, the disadvantages here are it's not very convenient for your patient. It's actually not convenient for your department as well to have to schedule patients 2 days in a row and things like that. And then timeliness of results can happen. You also have had, I've seen some areas where they did the 2-day protocol and people had, a patient didn't come back, or they've had issues getting whatever. So there's a lot of things that can happen with the 2-day protocol. It's not the most ideal, but again, it was kind of built from that thallium idea before things got changed. The other one you can do is a dual isotope imaging. And so with this one, they would start out with a thallium rest scan, and you would set the camera window to look at that 69 to 81 keV, and you do a rest scan with thallium, and that's not a great looking picture, but you could at least see on the rest scan if there was any defects. And then right after, you would do a stress with the sestamibi or with the cardiolite. And then you would set your camera to view the 140 keV, and because you can view those two different windows, the thallium and the sestamibi didn't get in each other's way. And this was one of the first ways that they said, okay, we can do a 1-day protocol. We just do dual isotopes and we can image it that way. Okay. And so here's an example of a dual isotope imaging. Again, I'm not going to spend a ton of time around here, especially since we're running out of time, but you can see that the stress, we have a defect in the stress, and the rest it was filled in with thallium. And so this is a positive scan. Okay. And then this is the one that most of you are probably using today. This is a stress rest protocol, and it's all done in 1 day. The difference here, imaging is the same on both, and it's the imaging we've already covered, so I'm not going to repeat these slides again. But the difference that we get here that's important to make a distinction between is that for a resting scan, we're going to start out with 8 to 10 millicuries. And you'll notice that that's about a couple of times less. It's about a third of what the full dose is for stress. Okay, so you have a low dose, high dose that you're using. Now, one advantage here is on the stress image, you're going to do that higher dose of 30 to 40 millicuries. So you're going to keep your image quality up. But on the resting scan, you're going to sacrifice a little bit of imaging quality for the opportunity to do it on the same day. And the question then naturally comes for this: why does this work? Why does it work? Okay. And it works because of a principle called shine through. Okay. So what is shine through? If you look at Waterstrom, they call it overridden. They use a term called overridden. But the idea is that we have a detection of radiation from a second source. And in this case, we have the stress image being a much higher dose of radiation. And that higher dose of radiation is going to shine through the 8 to 10 millicuries that you used on rest. And then your camera is going to level itself according to that higher dose of radiation. Your camera will look for the hottest pixel, and then it will line up all of your grayscale or your color scale based on that pixel. A good example of two sources of radiation that you don't always see happening, and it's not really two sources, but two different organs that are have a different amount of radiation in them, is a HIDA scan, right? So when you first give patient their dose on a HIDA scan and you stick them under the camera, oftentimes you're going to see a big liver, right? And you won't see anything of the gallbladder. And then as the gallbladder starts to fill, you see the gallbladder more and more and more and more. And eventually you get some washout of the liver and the gallbladder is really bright. However, if you're to the point of your HIDA scan and you can see that gallbladder bright, you don't see the liver much anymore, you can take your window, right? And you probably have done this before. You can grab your window and you can brighten up the counts. And lo and behold, there's the liver again. You can see it. Like, oh, it's still there. It still has some counts in it, but the counts are very, very, very low compared to what's now in the gallbladder, right? And so when you window and level, you can determine what you can see. And so that's what your camera is doing. Sorry, did someone have a question? Jack? Nope. Yes? Jack, did you have a question? No? All right. No, you're good. Oh, you're good, man. No worries. And so that's what's happening to make this work, is that your rest scan is so much lower that when you do your stress scan that's 3 times the amount, it's going to shine through and you're going to see that. It doesn't mean that if you pulled up your stress scan and there's a defect, it doesn't mean there's no counts in there at all. Those resting counts are probably still there, but they're so far in the background and so down that your camera has leveled everything to the new higher dose, okay? And so that's why it makes sense. They call that principle shine through or overridden. And that's why it works. And that's why we have to do a low dose and then a dose that's about 3 times the amount to be able to get that leveling and that shine through to work. Does that make sense? Any questions on that? Okay, let's look at some pics. Oh, well, I got advantages. Advantages, obviously, hopefully the advantages are pretty obvious. This is convenient for the patient. It's convenient for the department. It's convenient for put through, timeliness of results. Where we have some of the disadvantages is, we get a little bit of more patient dose. Whereas if you could only do the one, you might be able to get rid of the patient dose altogether. However, compared to a 2-day protocol, you actually are reducing the dose a little bit. So
I have a semi-related question.
go for it.
So regarding the stress imaging and that we use gating for it, even though we take the images like 45 minutes later, their heart rate shouldn't be as crazy as it was during the stress. So why do we use gating for the stress images?
Great question. And I love that you're thinking about that because you're actually right. They put gating, most places put gating on the stress. It's not going to be different. You're not going to have your rest and your stress gate would be the same because they're really both a resting gate. So I don't know if that was just over time they gated the stress. I don't know why they do that, but your thinking is absolutely accurate. Now on PET, that's different, right? Because when you do a PET scan, you are stressing the patient while you're imaging. And so you actually get a true exercise ejection fraction and a true rest ejection fraction. But on a SPECT camera, yeah, you're absolutely right. If you did it on rest, it would probably be the same as stress. So I don't know. I don't know why they still do it on stress. It's not a real stress EF. So good question. Any others? Okay, we have about 5 minutes left. So again, if you need it available when that time comes, that's fine. We're going to be pretty close. We're going to look at some pictures and go through a couple things, but we might be a tiny bit over, but hopefully not too much. I just wanted to pop in right here before we start looking at images, because we're going to talk about some pitfalls and ways to get around problems that can happen in your images. This is a problem that we've honed in on quite a bit at our department. We found it to be something that can cause a lot of issues. And last semester I talked about it when we talked about CT, using CT attenuation correction. Usually on your software, you're going to have somewhere where you can line up the CT scan with the perfusion scan. And it's super important to get those, not only have a good CT scan, but to get them lined up correctly. If you shift the perfusion off of the CT, then it won't attenuate correctly, and it can subtract counts out, and it can cause there to be what looks like defects that are not actually defects. So this is what our software looks like on our camera for lining these up. And these controls allow you to move it and get it lined up in a perfect position. On this first one, I pulled them way off of where they should be on purpose. So for example, the heart in the CT is here, and here's your perfusion down here. They're like way off. Just to give you an obvious example of it being way off. If we actually did recons based on this image, it would be terrible. You'd probably have defects all over the place. And then on the other one, I put it where it should be, and you can see that the perfusion is lining up perfectly with the CT. That's just an important step, and I don't want to just talk about this without mentioning that. Pay attention to that. If you get images and then you're noticing things don't make sense, you've got defects that you're wondering about, go back and look at your attenuation correction, look at the CT, make sure you're paying attention to stuff like that, because that can often be where problems happen. And it can prevent us from sending someone to the cath lab that doesn't need to go to the cath lab. So, okay, so here's kind of just like a good clean image of a Sestamibi product, Tech 99. You can see that the rest and the stress there, they both look pretty. We've got all of our views. This is kind of a normal scan, what it should look like. Looks pretty good. You can see on here there is a little bit of mild reduction in the apex right here. That very, very mild reduction where it's not quite black, just a little bit reduced, that can be a normal thing that you see on stress testing. And that just has to do with contraction of the heart during stress and then filling back up. Sometimes that apex will just naturally get a little less. When a cardiologist or radiologist looks at that, that's not an abnormal finding to have just a little bit less in the apex like you see on here. That's normal. Now, if it was blackened out, that's obviously not, but that can be a little bit of that apical thinning is what they call that, and that can be normal, okay? All right, I want to talk to you about polar maps, and we'll also talk about this more when we look at PET. But this is one of the data sets that's going to spit out when you go through your images and get them all ready. And this is another important thing to know as you're looking at images of what you're looking at. So if I took that cup, right, that we've talked about, and I placed it on a flat surface and then I flattened it out, that's what a polar map is. So in other words, the base of your heart is all the way around the edge and the apex is in the middle, okay? And this is what's called a 16-segment polar map. They'll break it up into these 16 sections. And then usually your software will give a value from 0 to 4 on how much perfusion is missing in that area. So a 4, if it gives it a value of 4, it'll be missing a lot. If it gives you a value of 1, or a value of 0, then it's not missing. Now in here, what they've done is these aren't those perfusion values. What this is they've just numbered these, and so you can know what the names of these sections are, okay? So again, this is placed just like you would see on our other pictures where you've got anterior here, inferior, lateral wall, septal wall, okay? So if you go down and look at these, for example, the one is they call basal anterior because it's the anterior side of the heart toward the base. If you come down to 13, you're going to notice that that's apical anterior, okay? So we're apical anterior, so basal apical, and then you'll notice that 7 is mid anterior. And so that's how these are named, and this is the way that you're going to see something on a report or when a doctor talks or when he's talking about where the defect is. They'll say he has a basal inferior defect or a defect in the basal inferior lateral wall. They'll use these terms, and that's what they mean is they're talking about the areas of the heart based on this polar map, okay? The other polar map you might see is instead of being based on segmentation, they base it in the coronary arteries. And so you'll have a map that shows LAD, circ, and RCA, and then these kind of sections that could be a mix between the two. So if I bring up a defect and I have it kind of on this anterior to the septal side, then that's going to be an LAD defect. Or same thing with RCA. So this shows you where that's located. When you look at your pictures, that's where you should expect defects based on those arteries to be located. Okay. So let's look at one. So here's a test. We got our stress on top, rest on bottom. What do you guys notice first? What do we got going on here? Who wants to talk? Who wants to be brave? Anybody even see any defects?
Looks like a reversible.
Yeah, go ahead. Henry, go ahead.
Oh yeah, it looks like a reversible defect, more towards the septal wall.
Yep, exactly. Let's look now. Now that you said that, you're exactly right, Henry. Go down now to the polar maps. What are we seeing on polar maps, and what is the polar map telling us? Remember, though, if you go back to this picture, we'll give you a quick look at that. Now we go back here. So these polar maps are not separated into segmentation. They're separated by coronary artery. So if we look at these pictures and we look at the polar map, what coronary artery is likely involved in this defect? What do you guys think?
LAD.
LAD, exactly. Who was that?
That was me, Jesse.
Jesse. Okay. I couldn't see over there. Okay. So, let me ask this question. And Jesse, you can stay on with me if you want, but if someone else wants to answer to you, I don't want to pressure you. But is that defect, you're right. Do you think that defect is likely, like the actual blockage in the coronary artery, is that likely kind of proximal to where the artery comes out of the aorta, or do you think it's further down the line more towards the apex, and why?
I'd say it's probably further down the line towards the apex, being that the center of the map is more blacked out than the base.
Exactly. You can see base here, right? Which tells you you're getting perfusion somewhere down that coronary artery, but then eventually, especially towards apical, you're getting the perfusion or the defect, right? So that tells us it's further down. You're exactly right. And the apex can be a funny place because some of these will kind of feed towards apical, like RCA is a very typical one. The RCA comes down and then it kind of swings under the apex of the heart at the very end. And so you can get RCA to apex, but what's nice about this one is you can see, and you should expect to see this, is you might see apical, but then you're kind of leaning towards that LAD. If it was RCA, you'd probably see apical and then leaning towards the RCA. So you can kind of get an idea there of kind of which direction it goes. But that's right. Thank you, Jesse. Perfect. Okay, so that's kind of identifying.
I have another quick question. Sorry.
Yeah, no.
So someone said reversible. By that, did they mean ischemia?
Yes, and that is what reversible means, and that this would be reversible. So you always, if you're talking about reversible, again, this is why it goes back to the funniness of thallium. They did stress first back in the old day, and so they would look and they would say we have a defect, and so then they would do the rest to verify. And if it reversed, then they'd be like, oh, it's reversible. That means it's ischemia, right? So you're exactly right. It's reversible and it's ischemia. What gets weird in our brains now is we do rest first and stress second. So using the word reverse is weird because we didn't reverse anything. In our brains, in your brain, you would think, well, I was good. I actually caused a defect. It's not reversed. It's like I made it happen now. So that's why the language can be kind of funny there. But you're absolutely right, Bree. That is what we would call reversible. Yep, not fixed. All right, so get used to looking at those whenever you can. You want to look at a heart, get a chance to look at those. When we look at PET, these same principles will apply, and we'll do some more images that we look at with PET when we get to that next time, and look at some more things. But I want to talk about some things that can happen and that cause problems, okay? So this is one of our big things that could be a problem with using a Sestamivi or tech-based product. What do you notice in these pictures? Somebody be brave and tell me what you see. If you're wrong, it's fine. Yeah, go ahead.
That's gut. So small bowel.
Yeah, it's gut, right? And thank you, Bree. You're absolutely right. And what you're noticing on here is that if you looked at this, you might think, man, that rest scan, like there's no perfusion in there. there actually is perfusion in there, but you've got this huge amount of gut that's coming over, and you'll notice that it's kind of blocking that inferior lateral wall. And because there's so much down there, it's brightened it up. And so we literally can't see the inferior wall on this. So that's a problem, right? Because you can't diagnose something if you can't see the inferior wall. You'll notice on the stress that it's similar. It's a little better. Like, I feel like we can sort of see the inferior wall. But can you imagine on this scan, like a doctor could look at this and get away and say, okay, I don't appreciate that these pictures are terrible pictures, but I can kind of at least see that there's not a defect down that inferior wall. But what if, you guys, what if this stress came up and there was a huge defect in this inferior wall? On this test, let's pretend there's a defect there and this one looks exactly like this. Can I tell if it's ischemia or if can I tell if it's fixed or reversible?
Probably not.
Yeah, you can't, because if there was a defect here, I can't tell if there's a defect on this rest scan in the inferior wall because the bowel is covering it. There could be one under there, but I can't see it. And so this is a problem. So on this test, this tech should not have accepted this rest scan. Okay, this is a rest scan that was accepted. And I'd be willing to bet, remember we talked about how hepatobiliary clearance is 30 to 90 minutes. That is why that is in there, because this tech probably did not wait. They probably gave him the rest dose and immediately put him on the camera. And you had this bowel problem. And then to make matters worse, they just were like, oh, well, and went on to the stress. So this is an example of what you do not want to do. Now, let me give you a couple caveats here, because if I had a patient like this and it came up and the rest looked like that, the question is, what can we do to fix it? And we can fix it. So one of the things is just waiting, okay? You're just gonna have to wait. You could stick your patient under the camera. Most of your cameras have a screen on them that shows the, before you actually start imaging, that shows you, the counts that you're looking at, and it starts to form an image. So you could put them on there, and a lot of times you can tell if the liver or the bowel is kind of up too close and there's no separation. So in that case, you want to wait. But even if you had done the images right away, you could still be like, okay, I got to correct this. We're going to wait, and I'm going to re-image at rest. And if you did that, you're likely to have that bowel out of the way. Remember, the tech-based product is brought in by the mitochondria, which means that when it brings it in, it keeps it there. It doesn't redistribute out. The gut doesn't keep it. It's there temporarily. It's not going to stay. It's going to move out over time. So your heart will stay, your gut will not. So that's the reason for the waiting here, okay? That's what you could have done. The other thing you can do during wait, on a rest scan, you can give them like some water to drink. Don't give them food, because we don't want to stimulate the gut to start, because that would cause a problem for the stress. But you can give them some water to drink. You can have them walk the halls. All those things will start to help to kind of weigh that area down and move it and push it and get it out of the way. Okay, but that's what you're going to want to do. Now let's look at what this looks like on a polar map. You can see the big problem here, right? It makes it look like we're most of the heart is not perfused, which just isn't the case. So not only are our normal images kind of garbage, but now our polar maps are garbage. The numbers that are giving them are just not, nothing's kind of good here. So here's an example of one that was done better by the tech. Okay, so what I have here is I have our rest scan. Okay, this is where we started. Then we have our stress scan, and then we repeated our stress scan. So the rest scan, it shows a little bit of gut. Now I would say that this gut on this rest scan is probably worth waiting a little longer. This tech did not wait, and I'll be merciful with whoever did this. I don't know who did the scan, but there is a little separation. A lot of times techs will look at that rest scan and say, all right, I feel like there's enough separation that we can see the entire wall. And I could accept that argument. If you want to get really good quality images, you could wait on this one too, and I guarantee you're going to get better images. Okay, so, but that doesn't always happen. I get it. This one, I can see why they went past it. I probably wouldn't, but I can see why they did. Okay, then they did their stress, thinking, oh, it's not that bad. Notice that their stress scan actually was much worse, right? So now the gut has taken counts away, and it is blocking some of that, kind of inferior septal wall, and so that's a problem. So now we have an issue on our stress. I can't guarantee there's not a defect down here, and that's an issue. So in this case, What happened on this one is this was a situation where they waited. And the other thing that's cool about the stress portion is at this point, if you've done this, if you're on stress, you've already done the rest and now you're doing the stress, you can actually have your patient eat something at this point. And this is a great way to get the gut and that bowel out of the way. The reason you can have them eat is you're not going to be doing any more injections. So now if they eat, it's going to go down and it's going to push that bowel. It's going to weigh, it's number one, it's going to weigh the stomach down and bring it away from the inferior wall of the heart. And it's going to cause stimulation to move the radiopharmaceutical out of the gut area. Okay. And so then this was our repeat stress. And now you can see that we still, even after doing that, we have a little bit of gut that showed up, but you can see a clear separation here. And so we can see that whole inferior wall. And now we've got something that's actually diagnostic. And luckily with this one, because it filled in and there's no defects on the stress, really everything that happened up with the rest doesn't really even matter at this point. The doc can look at this, he can give a great diagnosis, and everything looks good. Okay, so you want to keep an eye out for those kind of like pitfalls and possibilities. There's lots of different things that can happen and can occur. And we'll kind of mention some more of those as we go over PET. But that's kind of your general look with SPECT. That's all I've got. Any questions? Looks like people are talking about chug a glass of water. Yep. Cool. Okay. I'm gonna stop my share. Doesn't look like we're getting any questions. What time on April 8th? Someone just asked that. So April 8th, we're gonna do class at 8:30. And I'm gonna send you guys out an email so you don't have to remember it off of what I said. I'll send you out an email.
Go ahead and get.
Hey, Mike, I have a question.
Yeah, go for
it. Could you possibly go back to the screen where you have the polar maps with all the axial? Keep going.
Do we have another?
Actually, that one right there.
Sorry,
yeah, so
I think we're on a delay. This one?
No, it was the one where you had axials on top, and then it had both the vertical long axis, but then it had the the rest stress tech 99 cesta, maybe this one.
Okay. Wow, I didn't realize we had quite
at
a
our
delay.
Facility, at our facility, our techs are having some issues, and they had actually asked me if I could reach out. Their ejection fractions are almost always inverted, but looking at this, I'm curious because they have always been taught to shift those stress and rest frames where there's multiple frames to look similar.
Shoot, Tori.
So they're actually moving
you cut out. Go back just a little bit. Dang it. You cut out. Dang it. I didn't hear the last little bit. I heard you say something about frames, and that was
sure. I don't know how far back.
You're just cutting in and out, in and out, and out. Dang it.
It's probably just my internet. It's okay. I will send an email to you and maybe we can just discuss it or something.
Okay. Sorry. It keeps cutting in and out.
I'll try and reach out to you.
Okay. So that sounds good.
It's my internet.
Okay. Sounds good. Thanks, Tori.
Thanks, Mike.
Okay. Looks like we only have a couple people here left, so I'm going to go ahead and end unless either three of you have a question.
I have one more question. So that one polar maps, could you go back to that slide?
This one?
Do we have to memorize that left one for the boards? I mean, it's kind of self-explanatory. You can think your way through it, but
no, I don't think you're going to get questions. You might get a question of like a more generalized question of they show you like a picture of a heart and say, you know, where's this defect located, and then give you choices. I could see that being something, but in terms of like a memorization, no. But I would say that the more you go over cardiac stuff, you know, you'll kind of get some of this into your brain anyway. But yeah, but I would kind of know generally the general areas so that if someone gave you like a choice, you could do that. And then I would definitely understand this because I mean, this is only three things to kind of understand. Like, okay, where's my general LAD? Where's my circ? Where's my RCA? So good question. Okay. Lewis or Caleb, are you guys just hanging around for the goods? Or are you any questions?
I do have one question for you, actually.
Okay.
I feel like it is so hard to differentiate. I'm sorry, I can't speak either today. Between diaphragm or breast tissue when it brings up a false positive.
Yeah, no, that's a good question. And a lot of times, let me go to, especially one like this, that can definitely be a hard thing because a lot of times you'll see that breast tissue and it's a very similar block right here.
Gotcha.
It's kind of on that left side. One that if you're looking at these actual views, if it's more towards the septal, it's probably not breast, but yeah, it can be difficult. Um, with the difference between say something like this where you're getting counts and the breast tissue, what I would do is look at your CT to try to determine if it looks like there's an issue there. You'll probably have pictures that come up that won't look like this. It'll look just like is that what you're talking about? It'll look just like a defect that's there.
What? Yeah, it just throws a false positive saying either
Yeah.
there is a previous MI or a blockage going on.
So if you're questioning it, one thing that you can do is something that they call prone imaging.
Yep.
I don't know if you've done prone. Prone works really well for gut, but it can work for breast tissue too, especially usually with like patients that don't have a lot of breast tissue. You're probably not going to get an issue. It's usually going to be these patients with large breast tissue. And so what I would say is in the same way that you can flip the patient over prone, and what that does is it moves either whether it's a big large belly that they have or big breast, it's going to move those enough that then what you can do is you compare your stress images prone and your stress images supine. And if your defect moves, then you know that it's attenuation issue. If your defect doesn't move between the prone and the supine, then you've got it. That's probably the best way to do it if you're questioning breast tissue being the issue.
Yeah, and the cameras that we have, we don't have any CT.
Oh, you don't? Oh, so you're doing prone imaging anyway.
Yep. So we are doing prone only if the hospital or the radiologist calls for it.
Okay, gotcha. Then I would say that's going to be your key to if you guys are questioning that. That's probably the best thing you can do because you don't even have. It's not an attenuation correction issue in terms of correcting it, but the other thing too is that if your hospital eventually gets CT, that's one of the things that it helps kind of navigate is that it's going to take into account the breast tissue based on the CT. So I'm not surprised where you guys don't have CT on your camera that you're having issues like that. And prone is about the only thing you can do.
And we're a mobile group, so we actually don't have. We have some in-house cameras, but most of ours are in trailers.
Oh,
and we travel to 30, 40 different hospitals.
Oh yeah, that makes sense. So that's rougher because now your equipment, you can't even like, yeah, that's tough. I don't know. Yeah.
Right.
Yeah.
Okay. Well, cool. I appreciate it. Thank you.
Of course, no problem. All right, Lewis, unless you have a question, I'm going to end it. Okay, here we go. I'm out.